Hello everybody, my name is Joy Beasley. I'm a case manager. I work in private practice coordinating benefits for individuals who've been catastrophically injured in motor vehicle accidents. I have been doing this work for 28 years and counting. We're here today with Shannon McGrath, an occupational therapist and co-owner of Modern OT, a company that works with 40 occupational therapists in community-based rehabilitation, and Jill Petherick, a private speech and language pathologist that works in cognitive communication disorders with our clients. Early on in the pandemic, when my grandson was born in February of 2020, we had no idea that years later we would still be dealing with the effects of COVID. We were all hopeful that it would be over and we could get on with life. Because of COVID and the lockdowns and restrictions on practice, many of our clients suffered in the community. We know that rehabilitation services are essential to optimize both cognitive and physical function. And when the support we provide in the community was on hold during that lockdown, there was additional burdens placed on families, caregivers, personal support workers who seemed to be the only people that could access the community and provide support. Also, as the protocols and rules changed, PPE had to be purchased and utilized, and for fee-for-service providers, this was an extra cost in their businesses. As we started out in the pandemic, we saw our colleagues and clients were suffering. Kids were being homeschooled, people were taking care of elderly parents, trying to continue to provide rehabilitation services with a number of restrictions, and it was very difficult not to be able to see clients in person. Also, a reduction in income resulted, and we were all trying to do it all. Out of concern from my colleagues and my sense that people were feeling disrupted and upset, I worked with Bergeron Clifford to have a seminar presented on compassion fatigue. We need self-compassion in this time. And my goal was to help my colleagues let themselves off the hook from all of these extra responsibilities that resulted as a result of COVID. So again, self-compassion is important, easy to say, hard to put into practice. And the takeaways from this session were to retain the ability to think clearly, recognize the dangers of wear and tear, understand that we work with the fog that COVID brought us, ensure adequate social supports, and try and have some flexibility in work time. As a case manager, I connected with my clients by telephone. I'm not part of a regulated college, and as a consequence, I had no protocols to deal with in meeting with my clients. It was very clear to me that my clients were struggling. Already socially isolated because of their injuries, they were further socially isolated, and it's frustrating to deal with people when you can't see them, you can't engage in the kinds of rehabilitation activities they would normally be engaged in. They're socially disadvantaged. The rehab support for community engagement was non-existent, and also there was a higher suicide risk with the population that we deal with. I see clients in their homes now in normal times, but Zoom and telephone sessions make it difficult to get the whole picture. There's no opportunity to really observe body language, mobility, a sense of how they're managing their home and household. But my professional colleagues of all disciplines, speech and language pathology, occupational therapy, physiotherapy, psychologists, psychotherapists, rehab support workers, occupational therapy assistants, physiotherapy assistants, dietitians, and physicians rallied. Colleges eventually developed protocols to make it easier for clients to be seen. Zoom meetings became the order of the day, virtual sessions when possible. In-person sessions occurred. Today, most of the clinicians that I work with are using a hybrid model of a combination of in-person and virtual sessions. In my world, over this time, since the onset of COVID, there's been no transmission of COVID to any of our clients, nor have any of the therapists that I've worked with developed a COVID infection. We remain hopeful for that things will return to normal, whatever normal means. Thank you. I'd like to now introduce you to Jill Petherick, again, a speech and language pathologist that works with my clients with cognitive communication disorders.
Hi everyone. As Joy mentioned, I work in the community with people with brain injury as a speech language pathologist. Many people know that speech language pathologists work on speech or articulation, helping people to speak more clearly or precisely, but that is only a small part of my practice. The majority of the work that I do is in the area of cognitive communication. And cognitive communication disorders are impairments in communication stemming from cognitive deficits in areas such as attention, memory, organization, reasoning, executive functioning, insight, and judgment. Examples would be losing one's train of thought when talking, forgetting what to say by the time one's turn comes in a conversation, or being unable to keep track of a group conversation. Formulating thoughts into words and retrieving words are also parts of cognitive communication. Social communication is also a large part of my practice, as many people with brain injuries struggle socially for a number of reasons. Examples of social communication problems are a lack of a filter, so basically whatever pops into their head is what they say. Oversharing of information, inappropriate use of humor, poor judgment on appropriate topics or comments. Following an injury, many of my clients end up with social isolation from friends, breakups of families, and it can also contribute to mood disorders. I'm a traveling therapist, seeing people in their homes, schools, or other community locations such as libraries, parks, college or university campuses. Essentially, I will meet clients wherever it makes sense to do so. Looking back on the past 18 months, I think there have been 3 phases to the pandemic within my work. Phase 1, this was the initial shutdown starting in mid-March. At the time of the shutdown, 100% of my work was in person. But as we all know, in-person services were immediately halted by provincial order. Initially of utmost importance was to determine how to continue with treatment for clients given the pandemic restrictions. The first order of business was to find virtual platforms that met confidentiality requirements, and for me it was also very important to find one that was easy to use. Many of my clients do not have the executive function skills to download programs onto devices and manage multiple steps to connect to a virtual session. It was important that whatever method I chose, that it was secure but also user-friendly. Even still, there were some clients for whom virtual just wasn't a good solution. So for these clients, when possible, I was collaborating with family members and support staff that were still maintaining face-to-face contact to pass along manageable treatment tasks and continue with cognitive communication engagement as best as possible. Collaboration amongst rehab providers was also very important during this phase, so we could monitor our clients and make sure that they were doing okay. However, despite our best efforts, some clients were unable to receive any service, either directly or indirectly, during the initial shutdowns. I had one client with significant memory impairments residing in an assisted living facility. Understandably, staff were unable to provide the type of assistance he would need to manage virtual sessions with all the extra demands they had of the pandemic. And without the rehabilitation support he had been receiving, keeping him engaged through community outings and completing functional tasks of interest to him, he ended up spending most of his time in bed, and he declined immensely. In virtual therapy, there were many functional tasks dealing with technology for me to use in which to target cognitive communication skills. Supporting clients through errorless learning on how to use their new devices to connect with me, but also with others to encourage social engagement during a worldwide shutdown was an important goal. For those without technology, we collaborated as rehab teams to get the best technology for both now, but also for future purposes, and quite a few iPads were ordered during this time. These virtual sessions were so important to most of my clients. For many, speech-language pathology and occupational therapy were the only continued contact they had. Our sessions provided continued structure and routine for many who really struggled when their very busy rehab routine had been ground to a halt. For some, I was the only social contact they had in a day. And for these clients, my priority was to problem solve with them on how to increase their virtual social contacts, and using goal plan do reviews to make plans and set goals to keep them motivated and engaged during a time of little structure. For some, online courses, both free through places like Coursera and paid college courses through Ontario Learn were introduced as therapy tasks in order to provide higher level clients with meaningful activity for targeting cognitive communication goals through functional tasks. After completing 2 online college courses during this pandemic, one of my clients even went a step further and enrolled in full-time school this fall, and he started just this past Tuesday. Overall, phase 1 felt like a whirlwind. Pivoting from 100% in person to 100% virtual was a huge learning curve for both me and my clients. In June 2020, CastlePo, which is the regulating college for speech-language pathology, released information sessions on restarting patient care. Phase 2 involved sourcing PPE and determining adaptations to in-person therapy that comply with the point-of-care risk assessments and organizational risk assessments. In this phase, CastlePo had directed us to continue to provide virtual care wherever possible, but now in-person was allowable when deemed necessary. Working in the area of brain injury, I would have to say that the majority of my clients do best when seen in person. But at that time, for those who had adapted to the virtual, this was maintained. I began seeing clients in person in the summer of 2020. I screened myself and clients before each session. Because I don't work in a clinic setting, but instead I'm a guest in people's homes, I can't control all the variables for the organization risk assessment, so all sessions were conducted outdoors at that time. I brought my own chair, we sat 6 feet apart. No materials could be shared, so I used giant whiteboards to document session discussions and activities, and clients took pictures of the whiteboard instead of getting a paper handout. When I needed clients to see videos or reading passages, I airdropped things over to them on their iPads or phones. Sometimes we took session notes using a shared Google Docs document for those who could be more active participants in this process. Assessment materials such as response booklets were quarantined before administration and after. As an international university student, one of my clients did not have a private outdoor space since he was living with 3 other roommates in a very busy university student section. So since we couldn't use community spaces, they were all closed, we went for walks during our sessions, and key points were emailed to him after to help with recall. With all campus activities and facilities shut down and no family close by, these weekly walking speech-language pathology sessions were sometimes the only time he left the 4 walls of his room, and therefore were beneficial even beyond the realm of cognitive communication therapy. Overall, during phase 2, all clients were able to be accommodated either in person or virtual, receiving the same frequency of care with creative accommodations for the pandemic. None of my clients contracted COVID during this time. Though I would say one of the biggest barriers for me was being able to find a place to use the washroom. Phase 3 is the phase that I feel that we're in now. COVID procedures and protocols seem relatively stable, although that may change again with the 4th wave. I have a day of virtual treatment for clients who continue to do well with this way of providing treatment. For higher level clients, for which speech or articulation is a component of their goals, virtual can actually be preferable, as PPE must be worn during in-person sessions, making it challenging to see oral motor movements and model proper positioning and treatment strategies. Whether to see clients in person or virtual continues to be determined based on a consideration of a number of factors. For all others, we are back to in-person and operating both outdoors and indoors when necessary, using the required PPE. Beyond PPE, I continue to adapt my treatment to encourage distancing whenever possible. For example, I continue to use my whiteboards to write down key points. Another example is when working with college or university students on schoolwork, whereas I used to sit directly beside them in order to share a screen, we now mirror screens on each of our devices and sit physically distanced. Accommodations have been made and continue to be made as each client's situation is unique. A benefit of the pandemic is that I had to learn how to use virtual treatment, and most of my clients are now well versed in using the internet to connect on a variety of platforms. Zooming is now even a verb. For example, my clients will ask if we're Zooming or meeting in person. This means that when in-person sessions aren't possible, for example, a client needing to isolate due to a high-risk contact with COVID, they can be switched to virtual sessions without any lapse in treatment. I also had a client who went to another city to live in a residential treatment facility for a few months, but speech-language pathology was not provided to him there as an inpatient. Using virtual treatment, we were able to continue with our rehabilitation goals without any lapses. Being flexible has been necessary during this time, while also making sure to provide extra support to clients who thrive on routine and structure. They may need extra reminders about the change in therapy time and how therapy will be delivered that week should there be a change. Overall, there was much pivoting and modifications needed throughout the past 18 months. Ensuring clients had access to safe, quality care was the #1 priority, and working within strong collaborative rehab teams was extremely important. Work in community brain injury is complex, it is never straightforward, and there is never a one-size-fits-all approach. Virtual is now an option, but I still prefer in-person when working with clients with brain injury. There are so many ways to tailor therapy to be functional when you are seeing people in their home environment. I've been fortunate to work with a great community of professionals to provide continued rehabilitation to clients during this pandemic, and I believe our clients have been well served overall. Thank you.
Next up, I'd like to introduce Shannon McGrath. She's going to talk about the organizational challenges working with a large group of therapists and navigating the COVID-19 protocols, twists and turns. Thanks, Shannon.
Thank you, Joy and Jill. That was excellent presenting, and Jill gave us a lot of background on working through COVID from a clinician's perspective. As Joy mentioned, I'm an occupational therapist and co-owner of a private practice, Modern OT, which has clinics covering Kingston, Ottawa, and Pembroke. Throughout the 3 clinics, we have approximately 40 therapists, and we work in all sectors of private pay funding. So this includes motor vehicle accidents, Department of National Defense, Veterans Affairs work, WSIB and long-term disability, as well as corporate and government business work for health prevention and ergonomics. We also receive referrals through private pay customers. I think the scope of the work that we had kind of offers some background and insight into the changes throughout those sectors and the impacts of COVID. So I'm going to talk a little bit today about the organizational or the company perspective on COVID and the impact it had for us. So just to give some background, pre-COVID, the majority of our work as OTs took place in people's homes, in their work, in their communities. The essence of what OT does is therapy in the client's living environment. There was a component of telehealth for clients who lived very rurally where it was onerous or really expensive to provide service to them. So the college did have some telehealth guidelines, but I would say that they were sparse and it was not a practice that was widely used. So with the onset in March of 2020, with the shutdown, the initial shutdown due to COVID, the provincial government through public health ordered that only essential services are allowed to be provided for all regulated health care providers, and that regulated healthcare providers were to report to their local health authority to be prepared to be dispatched to support the hospitals depending on the outcome of COVID. For OTs, we were deemed to only provide essential services, and these services were defined as discharge services of clients in order to free up hospital beds for COVID patients. The college stated that all other in-person and virtual work had to be suspended. But discharge services were still very difficult for us to provide. So despite receiving phone calls from the hospital, there were very extreme shortages of personal support care and equipment delivery delays in the community. Many of the vendors and partners that we worked with in the community were closed, and even those that were open, they couldn't get the equipment through their distribution chains. So despite having an ability, we'll say, to work within discharge planning, the realities were that clients were being discharged home with minimal care, minimal equipment, and minimal in-person support from therapies. We were receiving at that time numerous calls from our clients related to the COVID situation. They were stressed about how this was impacting their mental health. They had increasing anxious and paranoid thoughts. We were also receiving calls from government agencies asking us to assist their employees for health prevention and adaptations for working from home. However, even despite these phone calls, given the mandate for the hold of all virtual and in-person services, we were not allowed to provide therapy. All of our OTs within Modern OT registered with public health to provide support to the hospitals. But in calling the number that was provided, the public health reported they weren't set up in order to have us as private practice clinicians work inside of the hospitals, because they are really two different areas of practice and two different silos of work. So although we were asked to do this, we couldn't actually be dispatched to the hospital to provide work. And so our OTs, 40 of us plus, remained idle, waiting to see when things would open up. So instead of kind of sitting back and relaxing, so to speak, Modern OT mobilized our occupational therapists to try to predict what the healthcare needs were going to be for our clients coming out of a pandemic. We predicted things such as virtual health platforms and the PPE measures that may come into place. We divided into practice groups and we looked at how we could provide care concerning mental health for our clients that we expected would be exacerbated, along with exposure therapy for people who would have to access the community again. We looked at protocols for preventing deterioration of our clients from a physical capacity during the shutdown as well. So all of these practice groups really helped position us in a good spot when things did eventually reopen. Eventually, as the cries from our clients increased, my business partner and I could not see why OTs could not be providing virtual healthcare to our clients, and that there was a protocols that needed to be developed. So moving forward, we did develop robust protocols for telehealth and virtual care, which included very similar to what Jill went through, but researching and trialing PHIPAA compliant virtual platforms, including such things as Zoom. We then moved to AdraCare, and now we use Microsoft Teams. We developed decision trees on how and what clients could be assessed and treated in a virtual manner and what areas may not be able to be assessed. We developed unique assessment methods during our virtual care, items such as screen sharing, online measures and tools that could be shared with clients and how they can be used. We had to develop new consent forms for virtual therapy, outlining for clients both their benefits and the limitations of therapy. We had to consider protection of their privacy as well when we're providing virtual services to them in their home. We developed new report writing standards and also recommendation standards based on the fact that our assessment and treatment would be provided virtually. We also shifted and developed and moved our pain management group, which used to be offered in person. We developed a process and system for how that could be offered virtually as well. Once we had some of these protocols in place and an idea of how care could be delivered to our clients in a responsive manner, we contacted the OT College in Ontario to discuss our concerns. We quickly realized that the college's focus had been largely on the portion of OTs that work in the public sector. So those servicing hospitals and those servicing home care, but working in a public manner. They hadn't actually put a lot of thought that almost 30% of the OTs in Ontario work in a private practice sector. This kind of just really fell off their radar. Once we brought this to their attention, the college was supportive of our ideas, and we collaborated with them on the protocols for virtual care. These were eventually published by the college and became the directives for OTs providing virtual care in the province. Just as Jill had mentioned, there was a second phase when the emergency order was lifted and the term emergency services was expanded for OTs to include the absence of therapy which would cause harm to a client. With this was the ability to start to see people in person again, following strict protocols. So coming out of that phase, or starting into that phase, I should say, Modern OT had to collaborate again to look at what would in-person sessions look like for us. We had to again determine which in-person sessions we could provide. We had to develop a COVID screening tool that could be found online, and also a protocol for doing a screening at the door at the time of an in-person assessment. We divided our assessments into two parts. One part was conducted virtually initially, and the other part was conducted in the home. This was to limit the amount of time that we spent in direct contact with a client. We developed protocols around wearing of our PPE as well as distribution of PPE for both ourselves and for our clients. There were protocols developed around maintaining our distance and what to do when we couldn't maintain distance. OTs work in the business of touching people. So when it was needed for us to be able to touch people, we had to have a decision tree for our clinicians to determine how they were going to do that and the length of time they were going to spend engaged in a therapy that involved touching. We looked at the ability to provide therapy outdoors as well as providing therapy in our clinics. We limited the attendance of other people in therapy sessions unless that person was required to be present for contribution to therapy, such as a caregiver or a partner that was providing care for a client. As a company, we provided training to our staff in these new assessments, in the new reporting, in all of the COVID screening. We had videos made on how to teach them to don and doff the proper PPE. We did instructional videos on how they would enter a client's home while minimizing the amount of items that they brought in. For instance, not their bag, but just maybe their chart and a pen. We looked at how they can reduce touching surfaces inside of clients' homes. The staff also needed training on technology in order to be able to best support themselves and also to support clients. As Jill had mentioned, many of our clients have difficulties with technologies, and some people are just new to technologies, and this was a very new experience for them. We created online documents that could be shared with clients while they were working with their OTs. So all of this was done, it felt like, very quickly and in short order. But in the end, it did change what practice looks like for us as OTs in the province. We continue now in our current order to still have a decision tree in place about when we need to do in-person care and when our goals can be met through virtual care. We do provide in-person care when it's practicable, and we do have, again, protocols that we follow with COVID screening and wearing of personal protective gear. Therapy now tends to be split, we find, between virtual and in-person sessions or in-clinic sessions. And there have been significant benefits that have come from developing the virtual practice platforms better. I'm happy to say that within Modern OT, with all of the interventions and protocols put in place, nobody on our staff and or clients contracted COVID throughout this. We did have lots of people who developed symptoms, and as Jill mentioned, having the option to switch care to virtual help meant that they were able to continue their care and their therapy throughout their isolation period. All of our staff as well really operated as a team. All of our clinicians are vaccinated now, and they were all and still continue to be compliant with all of the public health measures. I think it's important to note as well, as healthcare professionals, it was a drain on professional life, but also personal life, in that we all practiced public health measures strictly when we were at home because we knew that this was needed for our work as well. I'd say coming out of COVID on the other end at this point in time, or going into a fourth wave, we feel much more prepared. Our clients, as well as our therapists, have adjusted to some of the new normal and have realized the benefits that we can have from providing virtual health. In certain instances, it does take less time to provide virtual health. It can be certainly more cost effective because we're reducing the travel time and distances that we need to go to see people. At times, we get better buy-in from our client. They feel that they can fit in this session in between the other things that they're doing. It appears to be to them less of a time commitment at times, even because they can see us while their children might be home or while they might be isolating or having symptoms. On the downside, it definitely limits what we can observe in a client's home, the demeanor, their mood, their body language. It limits our ability to do certain types of physical and mental health assessment. So again, it's important that our clinicians recognize those limitations and are offering in-person care and following through with in-person care when able. Thanks very much. That's the end of my presentation, and I'm going to turn it back to Joy.
Hello again. That concludes our presentation. Hope you have a good perspective of how rehab went in the community from a personal level, from a single practitioner to a team. And we just thought we should mention, if you have any questions, please forward them to your practice leader, and we'll respond to any of them in writing. Thank you so much.